exaggerate. Okay. Sorry if I'm being vehement about it, but it's important. So we need to look at the choice of drugs if we do wind up wanting to treat it. And these next couple of slides are kind of wordy. They're just giving you information because we're going to go over the individual drugs themselves. But here are some situations where we might use an antibiotic. So periodontal disease, you've heard of ANUG, acute necrotizing ulcerative gingivitis, yes? Okay, or NUG, sometimes called. They sometimes will use penicillin VK, amoxicillin, metronidazole, or tetracycline. You don't have to memorize that whole list. We're going to go through these, okay? But those are the types of drugs that might be used. An abscess, which is a periodontal abscess. This doesn't mean every time there's an abscess we use this, but when we decide that we do need it, we use penicillin VK. Localized aggressive periodontitis. So we're talking about someone who develops, you take a full mouth series, they come in 2 years later and you're seeing pocket depth, you're seeing mobility. This is like out of the box kind of thing, but aggressive, very rapidly spreading periodontitis. We might use something like doxycycline or tetracycline, broader spectrum antibiotics. Again, we'll go over these things individually. Adult chronic periodontitis is generally not treated with drugs. Do we treat adult periodontitis with chronic periodontitis with drugs?
No.
No, okay, we don't. Unless we have a recurrent resistant acute infection that needs it, okay? But generally speaking, no, we treat it with what we do every single day in and out in dental hygiene practice. Rapidly advancing periodontitis, okay, just like the localized aggressive, something that's been going very quickly in a very short period of time, may be treated with some of those bigger guns, which is going to be your broader spectrum or your stronger antibiotics, which would be like the doxycycline, tetracycline, or metronidazole. Again, we'll talk about those. If we have a soft tissue infection, okay, something into like maybe a salivary gland or buccal mucosa or something along that line, soft tissue, VK, amoxicillin, which is starting to sound familiar. Osteomyelitis actually into the bone, maybe we're talking about someone who had an extraction that became infected. Penicillin VK, amoxicillin, drugs of choice. If we have a mixed infection that has become insensitive to penicillin, okay, if we determine that that infection is aerobic, you might use amoxicillin because it can do mixed. If we're talking about anaerobes, it may be something like metronidazole or clindamycin. Again, these should start to sound familiar. When we look at it, we try to treat it as gently as possible, but as it moves along, we have to get a little bit more aggressive. If we're doing prophylaxis for infective endocarditis, because we've determined through a decision process that is necessary, because it's not often necessary, okay? Like someone has a prosthetic heart valve and they have no penicillin allergy, we're going to use amoxicillin, okay? If they're allergic, we're going to use something else. Patient with localized aggressive periodontitis, doxycycline for 3 weeks, followed by the usual regimen. Again, these are cases where they've been treated repeatedly or have something growing very rapidly, then they may use those things. That's just an overview. We'll go through it one by one. The best defense, that's why I said the decision to use the antibiotic, the first thing we should think about is the host response and how immunocompetent or immunocompromised that person is. If that defense is lacking, these are some of the drugs that are used, okay? If they're taking, or the ones that we saw before, if they have these diseases or are taking these types of immunosuppressive drugs, certain diseases, we actually reduce the immune response in people, right? So we can fight whatever it is we're fighting, like when we're talking about cancer, okay? Or something like Addison's disease, age-related complex, cirrhosis of the liver, certain people with diabetes, especially if it's not well controlled, some Down syndrome patients that have resistance to infection, an immunoglobulin deficiency, leukemia, malnutrition, someone who just had a splenectomy. So these conditions, or taking these types of drugs that knock down our immune response, will help us to decide whether or not that infection that they now have requires the use of an antibiotic. So we would tend with these people to use the antibiotic rather than not. Okay, so there are conditions where we would do that. Okay. In periodontal diseases, we've already discussed, okay? If we've already treated it in the way that we know how, with localized, repeated root planing, debridement, everything that we're doing, and we still do not have good resolution. We should look at what the flora, okay, or the environment of bacteria are in that periodontal infection. All right? So debridement is our first choice of therapy for periodontal infection. Always remember that. But in lacking that, we can actually treat this locally first. And you guys have learned about the locally applied antibiotics. We talked about pumping stuff into the gums. Yeah? Starting to sound familiar? All right, because that's something you're going to learn how to do. And there are several products out there. Probably the most commonly one used is minocycline microspheres, and that's called Arrestin. You will learn how to place that. Doxycycline hyplate, which is Atrodox, and they're just delivered slightly differently. One is one use, and one has multiple use cartridges. And then something you will be using in the clinic would be a chlorhexidine rinse. Some of you may have used it already for your patients. And there's also locally applied, they're called perio-chip, and it's like a little, I hate to compare it to this, but it really looks like a little popcorn kernel. You know how good popcorn kernels are at getting stuck in your teeth? Okay, so I think they use that as an idea, and they actually place the little chip of it into the pocket. You might use that for people who cannot take systemic antibiotics, or whom you would not want to use one of the tetracyclines that was contraindicated for them. They can use the chlorhexidine. So sometimes if, women who are pregnant, they have a localized periodontal infection, and we don't want to throw an antibiotic, down their throat, or we don't want to use tetracycline, because we'll learn about why we shouldn't do that, right? Tetracycline, pregnant women, not a good thing, right? We might use something like the chlorhexidine rinse, or the little chips. Okay, so what are some of the general adverse reactions, and then we'll talk about specific drugs that have specific problems. But superinfection we already talked about. So you kill off enough of the bugs and we throw things out of balance, and we wind up with an overgrowth of some other type of infection. Allergic reactions, drug interactions, we'll go over each of these things. GI problems, that's the first thing I think of because that's the reaction that I've had, and also pregnancy considerations. So with the superinfection, again, that's that overgrowth of a different organism than the one that we were treating, because we're killing off one and we're causing the overgrowth of another. So this is where these words come into play. So the wider the spectrum, okay, the bigger the world of bacteria that we're treating by using a wide spectrum antibiotic, okay, and the longer we use it, okay, big wide spectrum, long period of time, the greater the chance of superinfection or overgrowth of other organisms. Okay, makes sense, right? So the longer you use it, the more you use it, the wider the spectrum, the more chance of having a superinfection that there is. So we minimize this by using really specific agents against specific bacteria, if we can, for the shortest period of time in inadequate doses, okay? You have non-compliant patients are probably the worst thing about infection, because they forget to take doses, they either take it for too short a period of time, they stop taking it before they should, or they keep missing doses. So they miss the dose, and then that bacteria starts growing again, and then they take one, and okay, it kills off some of it, and then they miss a couple more doses, and then it's growing again, and the bacteria is becoming stronger at this point. It's encouraging resistance, okay? We're teaching it, we're fighting it a little bit at a time, we're teaching it to become stronger. So using adequate doses, really educating your patient about how to take the antibiotic, not skipping doses. They've now developed, have you noticed, sometimes you're given a prescription, and you only have to take it like once or twice a day for a couple of days. Boom, you just kill it off, right? That's a good thing. Because if you give someone something that they have to take 4 times a day as opposed to twice a day, right, where are we going to get our better compliance? Twice a day, absolutely. Okay, and they've done studies on that. It actually works very well. Allergic reactions, we all hear about this, right? All anti-infectives have the potential to cause allergies, anything from mild or mild rash to anaphylactic shock. So it can really go the spectrum here, if you will. Penicillins and cephalosporins, which are related to penicillins, are more allergenic than others. You hear about people, what do they ask you every time you're allergic to penicillin? What are you allergic to? You're allergic to any antibiotics, okay? Erythromycin and clindamycin have low allergenic potential. They have other problems, but they have low allergenic potential by comparison. We've heard about the interactions between antibiotics and oral contraceptives. We've been told as clinicians, or you will be told, to educate your patient if they're using an oral contraceptive, and we have privy to that information because they've shared their medical history with us, that if we're going to be prescribing an antibiotic, that it may decrease the effectiveness of that. They think the reason for that is there are estrogens actually that are produced in our gut by bacteria. So by killing off the bacteria that produce the estrogens, we're throwing off the balance of hormones in their body, and that may reduce its effectiveness. That's kind of the theory about that. So you would have to advise your patient to use additional birth control measures, okay? And it's still a concern. It doesn't happen very often. There have been pregnancies associated with taking antibiotics. There have been lawsuits against dentists because of it. There's actually a couple of dentists that were required to pay child support. No, I'm serious, that really happened. So, and there's, again, some controversy about it, but it certainly doesn't hurt to have people be more careful. Yeah, this has really happened. Okay, so what about drug interactions? Anticoagulants are a big one. People are taking anticoagulants to literally thin their blood, and particularly the one that we're concerned about would be vitamin K antagonists, and the one we know most often is warfarin or Coumadin. Okay, lots of red flags go off in your head when you hear warfarin or Coumadin in terms of treating your patient, okay, and there's lots of reasons for that. It's because the bacteria in the flora and the intestine produce vitamin K. And the warfarin is a vitamin K antagonist. Vitamin K is involved in the blood coagulation process, okay? If we kill off the bacteria, okay, that produce the vitamin K, the warfarin now is like released in your blood and it has no vitamin K to antagonize, and it increases its effect by thinning your blood even more, okay? So they don't keep each other in check. So we now have someone who bleeds even worse than they would have bled before in taking an anticoagulant. So it can cause minor and major bleeding events. So this is something we want to be really, really careful for. And one of them, erythromycin, inhibits warfarin metabolism. So let's think. When we metabolize a drug, we package it up to excrete it and get rid of it. So if something inhibits it being metabolized, it stays and it keeps working. Bad, right? Okay? So the vitamin K thing, you give them something like erythromycin that inhibits their metabolism and it keeps working. We're calling for blood, problems. We're calling for bleeding problems. And it prolongs the international normalized ratio, which we'll talk about cardiovascular drugs. But that's the test that people that are on this particular anticoagulant are given to see what their bleeding time is. And when you're talking about someone on this drug and they're going to be having some sort of medical dental procedure, you have to make sure that their R&R value is correct. So you will be given the guidelines for that. So hemorrhaging can result. Okay, so anti-infectives can also interact with other anti-infectives. So they can compete for the same receptor and should not be given together. If you give a bacteriostatic agent and a bactericidal agent, the bactericidal agent works on the cell membrane of dividing microorganisms. So if you stop the bacteria from growing, the thing that attacks it while it's growing doesn't work. Okay, basically. So they kind of fight each other a little bit. Okay, they interact with each other. This is a big one, right? GI concerns, stomach pain, increased motility, that constant feeling of having to go, diarrhea, okay? Depending on the agent, depending on the dose, it can be quite severe. Yes, Deshanti. Is that Deshanti back there in the light? Yes. Clindamycin has a specific way of attacking the GI. Is that what you're talking about? Or are you talking about the warfarin? Of the warfarin? I don't know if that specifically has it. We'll get to that. But what you should do if you have somebody taking that drug, if you're concerned about somebody that's on warfarin, thinking about a patient, look to see if there's any drug interaction. Okay? But it's erythromycin that's known for having that effect. We looked at before. Where are we there? Inhibiting its metabolism. The way that some antibiotics work is by killing off the vitamin K as well. So there's a double whammy there. All right, clindamycin can actually cause pseudomembranous colitis. We'll get to that. Okay, cause bleeding. We'll get there. Okay. So erythromycin has the highest GI complaints of any of them. A lot of people, it affects their tummies, okay? Highest GI complaints. Serious pseudomembranous colitis can occur with clindamycin and other drugs. And again, we'll go over that when we go over clindamycin, okay? Pseudomembranous colitis is a severe inflammation of the colon and actually continual bloody diarrhea that can actually be fatal. So it's something that you really want to guard against and give our patients a lot of information if they start to have these kinds of problems. In terms of pregnancy, penicillin and erythromycin are considered safe, even though they do have some side effects. They're not associated with fetal teratogenicity, and they're often used in the case of needing an antibiotic. And contraindicated would be metronidazole because it has toxicity and can be transferred to the fetus, and tetracyclines because of the effects they have on teeth and bones. So skeletally and dentally can stain them and interfere actually with the process of the bones forming. So that would definitely be contraindicated. In terms of dose forms, we know that antibiotics come in a lot of forms. So there's tablets, there's capsules, there's liquids, there's chewables, injectables. And we should remember that cost of antibiotics, because some of the newer ones, right? Have you ever been shocked by a prescription? Some of the newer ones are extremely expensive. Some of the older ones are so cheap that I know there was some winters where I think it was Stop and Shop was giving away antibiotics free with any other prescription as a way to get people to bring their prescriptions there, because they're really, really inexpensive. But for your patients, especially, you're going to give them this new drug that's very specific for a bacteria that's extremely expensive. They might not get the prescription filled. So we have to be really careful in educating our patients about the antibiotics and using the right one. Okay, question for you. Antibiotic resistance may be reduced by culture and sensitivity testing of microorganisms, using large doses for long periods of time, prescribing an anti-infective only when absolutely necessary. All of these things, A and B.
A and C.
A and C. C is correct. What else?
A.
A, yeah. So we're going to go with F, A, and C. So if we culture the microorganisms to be specific about what we're using and prescribe it only when necessary, not for large doses for long periods of time, we're going to reduce antibiotic resistance. Okay, so now we're going to go over some of the specific ones and answer your questions about those. We're also going to talk about drugs for tuberculosis, topicals, and antibiotic prophylaxis in dentistry. And the last time I checked with Ms. Williams, we were on the same page with the antibiotic prophylaxis, but you be the scouts of that, and I'll check with her again. I usually talk to her before the lecture. I forgot today. But last time I looked at your P&P. I think we're on absolutely the same page. So penicillins, there are 4 major groups, penicillin G and B. Then there's the penicillinase-resistant penicillins, those that form an enzyme that eats the antibiotic rather than have it work on it. Amoxicillin, and then there's amoxicillin with clavulin in it, and that is called augmentin. We'll talk about why we use that. There are extended spectrum penicillins, and the drugs to know, the groups to know here in this group, and the penicillins are going to be penicillin G and B and amoxicillin, especially when we talk about dentistry. So those are the most common ones. They're useful in dentistry because they have bactericidal capability. They lack toxicity, they're quite safe, and they have a good spectrum of action for dentistry. They're effective against a lot of aerobic and anaerobic bacteria that are specifically seen in dental infections, and the spectrum varies on the different types. And amoxicillin, we kind of keep in the same class because it's a very close relative to it. And we know that if you're allergic to penicillin, you're also allergic to amoxicillin, but they're very, very close together. There are many, many uses, and your book has these giant tables, and you're thinking, I cannot memorize this whole table. So I'm really trying to specifically direct you towards the ones that you should know, but that information is at least there for you. Dose forms, orally, it's absorbed anywhere between 0 and 90%. That's not helpful. So it's variable, that's what that's telling you. It can be then given parenterally as well, but it should not be used topically. Highly allergic when used topically, so penicillins and topicals are not a good idea. Penicillin V is the one that's given orally, PO, which means by